along the lines of, well, when do you start asking about ablation? Our next case is by Dr. Genevieve Everett. She is our electrophysiologist at UPMC Altoona and came back into the UPMC system after many years recently and is going to show us a case.
Great, thank you very much. So this case that I'm presenting, as we've been going through the discussion today, I actually decided to change my patient a little bit. Still, we're going to use some of these same factors, but this is a 55-year-old male with history of hypertension, obesity, sleep apnea, and actually a patient that I saw at a similar age just this last fall, but had another factor. In the spirit of making this a little more challenging and maybe a little more controversial, he also has end-stage renal disease on dialysis. So he comes in and actually, I figure out how to work my pointer correctly. He was at dialysis. He went into atrial fibrillation with rapid ventricular response. He was having symptoms of lightheadedness and palpitations. He went into the emergency room. He was started on cardizem drip. They kept him overnight. He did spontaneously convert back to sinus rhythm the following day. So his entire AFib episode was around 20 hours in duration. He was started on metoprolol, and his resting EKG on metoprolol is shown here as well. So here's a patient who is on a rate control medication at this point. He's paroxysmal atrial fibrillation. He has a low resting heart rate with his metoprolol. And because of his end-stage renal disease, we are now absolutely limited in our options for antiarrhythmic medication. So our only option really for him would be to use amiodarone if he has recurrences of atrial fibrillation. And in this young guy at 55 years old, the long-term implications of amiodarone therapy are not really desirable. So this patient came to the office with me and already had in his mind, as Dr. Jan discussed, a lot of patients when they come to see the electrophysiologist have already talked to their referring primary care, their cardiologist, their friends, their cousin, and they have an idea about what they think they want to do. So he was in the mind of going for ablation to prevent recurrence. Now, this is a gentleman who's had an episode, albeit relatively long enough in duration that there's a good likelihood that he would have other sustained episodes, and especially these end-stage renal disease patients. Again, my bias speaking as someone who's getting consulted in the hospital to see AFib with RVR. If you have a person who gets paroxysmal atrial fibrillation, even if they're symptomatic, but they don't go to a dialysis unit 3 days a week, they're going to take a lot fewer trips to the emergency room. So the likelihood of this guy being back in the emergency room within the next few weeks or few months is extremely high. So how many times does he go to the emergency room? Does he get sent there from the dialysis unit before we say, all right, let's talk about AFib ablation? Sorry. So when we're considering treatment now, we may have risk factors where we're talking about in a younger, more relatively healthy patient, we may not have so much to wonder about. As far as additional risk factors, we can look at whether they're going to need, what their medication compliances are going to be, and how that's going to affect our decision making. But if we go with the options of medication, even when we're talking about antiarrhythmics, we have a really limited potential for success, especially compared to ablation in paroxysmal atrial fibrillation. We have proarrhythmic effects. A lot of antiarrhythmics require hospitalization, and that over the last 2 years, logistically, we've been very lucky to have these trials showing us advantage for going to ablation as an early or as first-line treatment, because our patients don't want to come to the hospital, especially during COVID, for initiation of antiarrhythmic class 3 antiarrhythmics. And a lot of the times we can't get them into the hospital because there's no room because we're taking care of COVID patients. So it's really become practically speaking, and as far as the data, a really good option to consider ablation as a first-line therapy for patients with atrial fibrillation.
Great, thank you. So I have a question there. I'll ask the panel. How many of you would say, we're going to wait longer? I want to see a longer stretch of AF. How many of you would say, well, you've had it now, we've got studies of first-line therapy? Bill, I'm going to start with you. When do you decide?
I was going to actually, if I'm on here, I was going to tell you I had a patient that fell into exactly that category. This gentleman came to see me because he had experienced the first episode of known AFib when he was undergoing colonoscopy. He spontaneously converted. You know, he had hypertension, but nothing else that really worried me too much. His CHADS VASC was 1, and so he didn't want anticoagulation, which was reasonable. And I said, you know, we don't have any information on you. Let's go ahead, give you an event monitor. Let's do an echo. We'll see you back. I ordered the event monitor to be placed on Friday. Friday night, we got a call that he was having AFib, 100 dead beats a minute. So I called him Saturday morning and said, you're now going on to Eliquis, and we will talk again after you get the echo done. But I'm inclined to probably push him towards doing ablation because he's early and we have no clue as to how much.
Would symptoms change your mind? So
Symptoms
let's say they were completely
yeah.
asymptomatic. Would you say, I'm going to give it some time?
I don't know. I'm leaning more and more. You know, I have been reluctant to push people right to AFib ablation a lot of times because I'm not sure I'm comfortable with the 75% or so success rate that we get. I know that we aren't a whole lot better with medicines, but I do have a feeling that people have to get used to this idea. They have to buy into it as well. And I feel that if we get them on anticoagulation and they're safe, we can try medicines. And I find many people feel much better if they've had a medicine, it doesn't work, and then we go and move them on to ablation. No, I guess I'm a little more conservative, but there are people that I say, I think, you know, you're not going to succeed with the medicine and you want to go on to ablation.
So Genevieve, there's a good question in the chat that I think you are best to answer. If any of you develop 8 hours of AF on your Apple Watch after a well-deserved cocktail shaker tonight, after you drive home, and have a recurrence during a stressful PVI ablation next week, what are you going to do? What's your next step? So based on your case, are you going to call one of your colleagues and say, I'm ready for an AF ablation after this?
I think that's an excellent question. And, you know, in our discussions today, talking about what's available for treatment of atrial fibrillation, we've touched on the fact that although our success of ablation, we still haven't found our silver bullet. The procedural times and complication rates of these have evolved unbelievably over the past 2 decades. I mean, you know, AFib ablation used to be an all-day affair, and now it's a couple of hours, and patients are going home same day or next day. And I mean, it's I would go early, I think, for the ablation, just because you know, as opposed to the in and out of hospital. It kind of sounds silly when I talk to patients about coming to the hospital and hanging out and watching Jerry Springer for 72 hours while they start and initiate dofetilide, as opposed to, or you can come and we can do an ablation and you can have 3 hours bed rest and a follow-up echo and go home and see how you do first. So I would move sooner to ablation, even myself, I believe. Easy to say, hypothetically.
I'll throw my 2 cents in. I would probably do ablation if it were me.
Well, it's good that at least the card-carrying electrophysiologists have some belief in what they do.
I would go to ablation most likely. I mean, I might be in that like 2 to 3% that you talked about with regards to athletes and the amount of exercise that I do per week. So I'm not going to have a heart attack, I don't think, but I might have a, and so I would, because strokes scare me, and I would prefer to decrease the risk of those, thinking that at least one ablation, if not two, would.
So I'm going to harp on that one, Dr. Berlecker. So Mahak, do you tell your patients when you're with Dr. Estes or Dr. Sava in clinic that the reason you should get your AF ablation is because their stroke risk is going to get impacted?
Well, that is one of the first things we discuss because in management of AFib, that's one of the first things that does come up. But I will say that risk factor modification still has a huge role to play. Again, comes down to the age of the patient, comorbidities. And I've seen Dr. Berlecker push a monster truck during the cardio fit boot camp. So I do believe that she probably does the level of exercise that puts her at high risk of recurrent AF. But for most patients, I think there's a lot of room for work to do before, for me, the question is always, how long do you wait? How long should we wait for them to go from paroxysmal to long-standing, persistent, and permanent?
Well, and I think what Sandeep's getting at is, do I think that the ablation that Genevieve is going to do on me prevents my stroke down the line? And I think we don't have good data to suggest, Bill, what you were talking about, which is how much. My hope would be that I never have AFib again. The reality is that I would probably have something at some point, given I'm 40s and I hope to live till my 90s. So I would still have to have that discussion about, as I age, at what point do I need to think about anticoagulation?
Right.
That's a good point, because we all have patients that come in to us for ablation who are asymptomatic and sometimes long-standing, persistent, asymptomatic, well-rate controlled, normal EF, but they want to have an AFib ablation, get back in sinus rhythm so that they don't have to be on anticoagulation. And it's a discussion with them, and especially even though in patients who are paroxysmal, and again, want an AFib ablation to get off of anticoagulation. That unfortunately, that isn't the case. And the data, and you've seen a lot of data today showing that although we have success, depending on the patient and the persistence of their AFib or their AFib burden, we are not nearing 90 or 100% where we can confidently take people off of anticoagulation in a lot of circumstances.
One of the things I think that I'm hearing too is a changing in thinking that I have to fail antiarrhythmic therapy most, if not all of the time, before I even consider ablation. So given the situation, we can go right to ablation versus saying, okay, we have to really try.
But I'll add that many times patients are scared to death of you screwing around with their heart. And so sometimes the medication is what you do as a first step to get them used to the idea. But yeah, I think there's still a lot of that. I still see many people that look at ablation as the last step.
Hey, Genevieve, can I ask a quick question?
Please.
Hey, nice talk. Question for you. So even in Erie, we're seeing more and more people who are coming to see us, not sue us, to get an ablation, right?
Mm-hmm.
This is not just a young population. This is people in their 60s and 70s. They're familiar with the procedure. Where do you draw the line for direct to PVI as opposed to using an antiarrhythmic, as Dr. Picone mentioned, as a starting step? Is it paroxysmal versus persistent? Would you go direct to PVI for a persistent patient and not even introduce an antiarrhythmic? What's your approach to that?
That's a really great question. And I would say, again, in these last couple of years, because of data and quite frankly, because of logistics, I have come to the point where I am often talking to patients about an either or approach when they come to see me. These are the medications that we have. This is the procedure. These are the pros and cons. And again, like Dr. Barrington said, I have a lady that I saw on Tuesday who had a relative that had a device infection. So kind of not really related at all, but she said, there is no way you're getting me into the hospital for a cardiac procedure, period. And versus patients who say, I don't want to be on meds, or I want to be on as few meds as possible. I don't tolerate medications well. And there are lots of people that have sensitivities, especially because of the fact that most of our antiarrhythmics also cause bradycardia, and they have baseline bradycardia. And, really the idea of, which I would have been doing more maybe 5 or 10 years ago, or putting in a pacer so I could keep somebody on Sotalol. And now I'd say, let's think about AFib ablation. And again, with the duration of the procedure being very short, I mean, we're talking, an hour and a half to, 3 hours at those veins that are really being stubborn for you. But I mean, these are short procedure times. I've expanded a lot as far as the age range that I'm offering to, well into the 70s.
I mean, I liken it a little bit to, it used to be the difference between the discussion of an SVT ablation from the logistics and safety standpoint was a lot different than AF ablation, but that's not so much the case anymore. The efficacy, though, I really spend a lot of time honing in on, well, why are we doing this? Mm-hmm. That 30%, what happens 6 months later in those 30% that are going to have AF? What happens to, for the reason of burden and improvement in symptoms? Because I think sometimes patients go into this thinking it's like going to be an SVT ablation where it's one and done.
Right.
And we know it often isn't. Excellent. One last one from the chat, and we'll move on to our next comment that's somewhat related. Any information on how you manage AF with acute COVID infection, and do you treat it differently?
That's an excellent question. And, we're at a phase, obviously, because we've been dealing with COVID for these last couple of years, that it's early on to know what the long-term results are for these patients, meaning will they have recurrent AFib? And we see these AFib episodes that are one and done. It's a known factor that we've seen in the flu. We've seen it in surgical procedures where patients have AFib after that infection or procedure, and then go on to have several years at least being AFib free. And again, I would say it's symptom driven. I definitely see, as far as AFib and just tachycardia in general, a lot of sinus tachycardia, where people have persistent symptoms for months and months after COVID infection. I've had patients who have documented AFib, paroxysmal AFib after vaccination, which I probably shouldn't say because we want to get everybody vaccinated. But I mean, we're seeing a lot of this. And again, I do try to manage them a little more conservatively because I do think that a lot of them will get better, but it's been taking 6-8 months or more. So depending on how symptomatic they are, if they are very symptomatic and it's becoming disruptive to their life, then offering them treatment options.
Yeah, I mean, we all, I think, like to think there's some acute insult that triggered this, just like a post-op episode. Maybe there's an underlying substrate there, but that will manifest itself later, right? You're not taking them from the isolation room to
no.
All right.
No, yeah, I try to do televisit consults for most of my COVID patients as much as possible. Wait till they're better.
Excellent. Thank you very much. That was great.